to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of imaging services exclusively for doctors. Clarinet is selected to be chosen as a general partner for this event organized by Indian Society of Anesthesiologists. So today's focus would be anesthesia obesity. Let's begin today's session, for which I would like to invite Dr.AL.Meenakshi Sundaram sir, who holds degrees in MBBS, DA.MD, Administrator Dean, and DME in Government Medical Colleges, Theni, Chennai, Professor of Anesthesiology, Thanjavur, and Tirunelveli Medical College, National Vice President, Indian Society of Anesthesiologists 2016. National Governing Council member, Indian Society of Anesthesiologists 2009 to 2012, President ISA Tamil Nadu State Branch 2011 to 2012. State Secretary Indian Society of Anesthesiologists Tamil Nadu State Branch 2006 to 2010. So without any further delay, sir, I would like to hand over the session to you. Kindly proceed, talk, sir. Over to you.
Thank you, Clarinet. At the outset, I request our branch president, Dr. Munian, to offer his presidential address.
Good evening to all. I am Dr. K. Munian, President ISA, Pudukkottai City Branch. On behalf of ISA City Branch Pudukkottai, I am welcome Honorable Moderator and speakers and esteemed colleagues for the online webinar conducted in the name of Pudukkottai Bhudhan. Today, we are going to conduct 15th episode of second edition of Pudukkottai Bhudhan. Today, our speakers are going to talk about anesthesia for patients with obesity. As a prevalent, I am honored to address the critical role of anesthesia for patients with obesity. As the prevalence of obesity continues to rise, anesthesiologists face the unique challenges in providing effective care to the patients with obesity. What are the key considerations in obesity? Physiological changes. Obesity is associated with significant physiological changes, including altered respiratory mechanisms, cardiovascular disease, and metabolic disorders like diabetes, hypertension, and obesity. What are the challenges we are facing? Anesthesiologists must carefully consider the impact of obesity on anesthetic management, including airway management, ventilations, and hemodynamic stability. For overcome these difficulties we are facing, we have to need multidisciplinary approach like we have to collaborate with the surgeons, primary care physicians, and healthcare professionals for giving optimal care for our patients. What are the techniques are used? Regional anesthetic techniques more suitable for such patients like spinal and epidurals. In some conditions, when general anesthesia is required, careful planning and executions are very important for a safe anesthesia outcome. Airway management is a critical aspect of anesthesia care for patients with obesity. Then perioperative care like thorough perioperative evaluations and intraoperative care and postoperative care. Speakers will give excellent explanations regarding perioperative, paraoperative, and postoperative cares. By understanding the unique challenges and consideration of anesthesia for patients with obesity, we can optimal care and improve the patient's outcome. Today, we are gathering for online webinar conducted by ISA Pudukkottai City Branch. Today, our speakers are very interested to share their experience with all of us. Thank you, sir. Welcome. Thank you, sir.
Thanks, President, sir. Now I request our Secretary, Dr. Kannan, to present his secretary address.
Good evening all. I am Dr. Kannan, Secretary, ISA Pudukkottai City Branch. Successfully, we are conducting 15th webinar of second edition of Pudukkottai today. Today, our topic is anesthesia in obesity. I welcome all our eminent speakers to the webinar. I welcome all the participating delegates to the webinar. Last week, 23rd April, we have conducted 14th webinar of second edition of Pudukkottai smoothly. Last webinar topic was segmental spinal anesthesia. Our moderator was Dr. Richard Chandra, Professor, Rokiran Medical College, Uttar Pradesh. We have divided the topic into 3 subtopics. First one is density, specific gravity, and varicity. Second subtopic is safety concerns in segmental spinal anesthesia. And third subtopic is practical tips in segmental spinal anesthesia. First subtopic was done by Dr. Geeta Varsini. She is postgraduate Mahatma Gandhi Medical College and Research Institute, Pudukkottai. Dr. Geetavashini started with the definitions of density and explained about high, medium, and low density with pictures. She has given the definition of specific gravity and baricity and classification of baricity, that is isobaric, hyperbaric, hypobaric. She has given the values of density and height and specific gravity of local anesthetic agents. Second subtopic is safety concerns in segmental spinal anesthesia. This topic was done by Dr. Sirish Mahaveer. He is associate professor, Dr. Punjab Bravo, Deshwar Medical College, Maharashtra. Dr. Shahbaz started with the introduction to segmental spinal anesthesia and explained about the safety concerns in segmental spinal anesthesia, neurological injuries, bradycardia and hypotension, ventilatory impairment, high spinal and total spinal anesthesia, medical legal issues. He has explained the anatomy of spinal cord with diagrammatic representation and at different levels of spinal cord. He has said segmental spinal procedures with multiple slides. He has explained the mechanism of bradycardia and hypotension with the reflexes involved, and also mechanism of muscles involved in respiratory functions and the pathology of respiratory impairment. He has covered the high spinal and total spinal and medico-legal issues we facing in segmental spinal anesthesia. And third subtopic is practical tips in segmental spinal anesthesia. This topic was done by Dr. Naresh Paliwal. He is Professor Emeritus. Dr. Anaesthesia started with the articles which are published in the view of thoracic spinal anesthesia. He has explained with the introduction to segmental spinal anesthesia, factors involving in segmental spinal feasible, safety concerns in segmental spinal anesthesia, feasibility of segmental spinal and caudal anesthesia, different modes of using segmental spinal anesthesia, and types of spinal needles we are using, comparison of segmental epidural versus segmental spinal, and he has shared many slides of the procedures and videos of segmental spinal and epidural procedures. Last webinar was attended by 947 delegates. We need your continuous support to continue this academic program successfully. We thank our academic chairman, Dr. Meenakshi sir. Academic faculties, kindly encourage your postgraduates to attend our webinar continuously, which are very helpful in the exams. Thank you all.
Thank you, Secretary. And now it is my duty to introduce the faculty members in my thematic address. See, actually, I am very happy because last session, the moderator was from Uttar Pradesh. And this time, the Uttar Pradesh state is participating in the entire webinar. And the advantage here is we have 3 professors. That is a great thing with 1 postgraduates. Usually, one assistant will be talking if faculties from college. So that shows that Theerthanker Medical College is having a rich resource of academic faculties because we have 2 professors and 1 professor and HOD are the faculty here with a little master, Dr.Trapti Singh. So Dr.Trapti Singh, she is the youngest faculty today, and she has done her MBBS from Barabangi, and she is doing her anesthesia residency under the able guidance of 3 professors in Theerthanker Medical College. And she's the more flexible graduate. The professors say she is obedient. But what I feel, all postgraduates will seem to be obedient to their professors. But all the professors say she is obedient as far as their knowledge is concerned. And she is determined. She is a hard worker and persuasive. And she has taken part in the cadaveric workshop. That is cadaveric airway, I think. She has done great work in that because Dr. Jain happens to be the secretary for that. So naturally, our postgraduate will be interested in that. And she is very quiet, keeping quiet. See, her name is Trapti, but usually to detect ischemia, we will do Trapti. So she is very quiet. So she will definitely people moving with her will not develop ischemia. So the Trapti is always negative for them because the Trapti is very quiet. So I welcome Trapti for the thing. And it is followed by Dr. Shahbaz Alam. See, in Tamil, if you say Shahbaz, it means very good. So he is a very good candidate, Shahbaz Alam. So we are happy to have you here, ever smiling graduate. So that मुस्कुराहट तो बहुत अच्छा लगता है. So he is ever smiling. Really, he is obedient. I know he is obedient because his thesis guide is Dr. Syed Moeed from Aligarh University. So I know him for so many years, and he also certified. Yes, he is a good candidate. Now he is a professor. So the second line has come, and he was organizing faculty for many conferences and for BLS program, ACLS program, everything he will do the thing. He was a faculty speaker. He is a life member not only in ISA but RSACP also, and his area of interest is airway management. And a number of publications, 12. So that is a great. All the three, they have good publications in national and international journals that shows their caliber, and that speaks a lot about Theerthanker Medical College, where the youngest professor is doing 9 papers, means the senior professor is doing more. That Dr.Payal Jain madam, she is instrumental in fixing up this webinar because she is the one who has dropped a message. So we are very happy that the Theerthanker Medical College has come forward on its own. So we reciprocate the same. And just because the junior professor has done 12, Dr. Payal Jain has published 15 papers. So she has 15 publications, and she is the scientific secretary for that cadaveric airway society. That is the reason why Dr.Trapti Singh has also done so many things, and she is organizing faculty for UP ISACon, and she is very much interested. Wherever I meet her, it will be only in the conference. So she is ever active, and the moment an academic program is coming, he will immediately capture that. So to govern these people, we need a big line because all these people are line. So we have that Dr. Mukesh Kumar Prasad. So he is a professor and HOD. So he governs them in their department. Now he is going to govern here also. So Sir is a great faculty. So he had been the organizer, speaker, chairperson in various conferences. And just because he is a HOD, he has published 40 publications. See, this is enormous. So one is 12, next is 15, another is 40, means Dr. Payal Jain is going to touch 40. Dr. Shahbaz Alam is going to touch 40. At that time, Trapti Singh will be the assistant professor or associate professor. I don't know. But this team is very good. We have to encourage this team. Really big thing. And sir, this HOD sir, he has not only written the scientific articles, he has written non-scientific articles also, like the missing rhythm. See, the missing rhythm means everybody is living with the rhythm. So he has done missing rhythm and abstract. We have seen only back-to-back scenes in YouTube, but here it is abstract to abstract is a great thing. And he is a reviewer of national and international journals. He has written 9 book chapters. So that is a great thing. More than the publications, that means he is taking an active interest. And in spite of being such a great academician who has written 9 book chapters and 40 publications, he has come to Pudukkottai Budhan to deliver his academic caliber to the youngsters in anesthesia. So he has done so much during COVID era, and he has got so many appreciation from the government. And he is currently the executive member of ISA city branch, that is Moradabad. So such a great faculty are taking part in Pudukkottai Budhan in this time. So I welcome all of you. I hand over the session to Dr. Mukesh Kumar Prasad. The question and answer discussion will be only at the end of all the 3 lectures. Thank you, sir.
Thank you, sir. Good evening, everyone. So at the outset, let me thank ALM sir for giving us this opportunity to be a part of this academic extravaganza. I am also thankful to Dr. Manian sir, Kannan sir, and Hema madam for considering us for this session. I am very proud to say that these webinar has already achieved milestones in terms of viewership, which shows the popularity of sir as well as the way the webinar is conducted. So now coming to our topic for today, where we will be conducting an important session on perioperative management of obese patients. So as we know, obesity has become a global epidemic, and with it, the challenges faced by anesthesiologists and perioperative teams have grown immensely. So this session is designed to walk us through the journey of managing an obese patient, from understanding the physiological changes to preoperative planning, and finally to form an intraoperative and postoperative strategies. So for this, we have three speakers with us today who will be guiding us through these aspects. So our first speaker is Dr. Trapti Singh, a final year student, who will start us off by exploring the pathophysiology of the obesity and understanding the underlying changes in cardiovascular, respiratory, endocrine, and other systems essential for safe anesthesia care in obese patients. So I would like to invite Dr. Trapti. Go ahead with your presentation. Share your slides, Dr. Trapti. Dr. Trapti, please share your
Yes, sir.
slides.
Yes, sir. Yes, sir. Good evening to all esteemed ISA faculty members, respected HOD sir, and all the designated faculty. I sincerely thank the ISA faculty and HOD sir for granting me this opportunity and platform to deliver my seminar. Today, I will be presenting a seminar on anesthesia and obesity, focusing on the introduction and pathophysiology of the obesity. The table of contents are definition, classification, types, factor affecting obesity, size descriptor of obesity, and effect on the various systems. Definition: the abnormal high amount of adipose tissues as compared to the lean body mass is known as obesity. According to the WHO, the obesity defined as a BMI more than or equal to 30 kg per meter square and the morbid obesity as a more than 40 kg per meter square. CDC defines the childhood obesity as a BMI more than 95 percentile according to the growth chart. Obesity most frequently develops when the food calorie intake is more than the energy expenditure over a long period. Body mass index is calculated by weight in the kg by height in meter square. The classification of obesity as different BMI ranges are classified into the categories as underweight, normal, overweight, obese class 1, obesity class 2, extremely obese, super obese, or super obese. And the waist circumference helps in the predicting the risk of the health problem related to the obesity. According to the Asian guidelines, the BMI is defined as less than 18.5 kg per meter square is underweight. The normal range is 18.5 to 22.9. Overweight at risk is more than 23 to 24.9. And obese class 1 comes in category of 25 to 29.9 and obese class 2 is more than 30. The measurement of obesity, the accurate measurement of body fat content is difficult, requires the sophisticated techniques. Therefore, the clinical approaches are used. Anthropometry helps in diagnosing of different grade of obesity and accessing the fat distribution. Densitometry tells about the percentage of fat versus lean mass, body mass index, and the ideal body weight. Other parameters are waist circumference, which correlates with the abdominal fat, as the male is in the high risk if more than or equal to 102 centimeters, and the female is in the high risk if it is more than or equal to 88 centimeters. Weight to hip ratio is independent high risk factor for IHD, stroke, and diabetes, as a male is in the high risk if the ratio is more than 1, and the female is in the high risk if the ratio is more than 0.8. The distribution of fat and obesity induced morbidity are of two types, android and gynecoid. Android is also known as the central obesity. The adipose tissue predominantly is present in the upper body part. This fat more metabolically active, so the high oxygen consumption is required, which increases the incidence of cardiovascular disease and mainly found in the males. Gynecoid type is also known as the peripheral obesity. Adipose tissue is mainly prominently present in the hip, buttocks, and a thigh region, required less oxygen consumption, has a less associated with the cardiovascular disease, and most commonly present in the female. The factor affecting obesities are as the energy intake and the expenditure. This balance control the person body weight set point. And the factor affecting these are like biological factors as the birth and the natural aging process affect the weight. That is, the low and the high birth weight leads to the obesity. The female genders are more prone for the obesity. Second is the genes, as the genetic factors make the person to more obese. Environmental factors, eating habits, and physical activities which ease the access to the junk food. Behavior factors, the personal choice of habits strongly affects the obesity, that is, the binge eating and the sedentary lifestyle. The size descriptors used in the obesities are total body weight, that is, the lean body weight, and the fat weight. Adjusted body weight is the ideal weight and varying degree of the weight excess. Lean body weight is the weight of the muscle, bone, ligament, and the body fat. Ideal body weight is the weight associated with the lowest mortality rate for the giving height and the gender. Predicted body weight is the lean body weight and the fraction of the individual fat content that represent the predicted normal fat mass. Now, the systemic effect of the obesity. As obesity widespread effect across all the body system, each system is stressed by the excess weight, leading to the multiple health complication. Now, we will discuss one by one as listed. Firstly, the effect of immune system. Obesity itself is a state of inflammation. This diagram This diagram shows that the increase in the fat leading to the chronic inflammation. Causes are recruitment of the macrophages, death of adipocytes, and and fat excessive expresses the low oxygenation, which causes the hypoxia and leads to the oxidative stress. These all factors triggers the inflammation by releasing the factors like interleukin 6, TNF alpha, decrease in the level of the adenoneptin, which these all factor causes the endothelial dysfunction, insulin resistance, and increase in the lipolysis. The effect on the effect on the obesity on respiratory physiology. This we will discuss with the help of pictorial chart presentation. Now, the most common respiratory changes occur in the obesity is restrictive lung disease. It begins with the increased fat and decreased respiratory muscle function, which leads to decrease in the chest wall compliance and increased elastic resistance. Simultaneously, decrease in the pulmonary blood flow and decrease in the lung compliance result as a total decrease in the respiratory compliance, that is, decrease in the FRC, decrease in the vital capacity, decrease in the total lung volume. Due to these limitations, the shallow and the rapid breathing and increased work of breathing occur. On the vascular side, increase in the total volume and the pulmonary blood flow leads to the polycythemia and causes the chronic hypoxemia. Simultaneously, the FRC decreases below the level of the closing capacity as the small airway collapse prematurely and causing the VQ mismatch and the right to left shunt. This leads to the arterial hypoxemia. As this diagram shows that the effect of obesity and positioning on the lung volume. 50% reduction in the FRC occurs in the obese anesthetized patient compared with the 20% in the non-obese patients. Normally, in non-obese patient, FRC is more than the closing capacity, that is, the small airways open and the normal breathing occur. But in the obese upright position, FRC decreases but still above the level of the closing capacity. Therefore, the risk of the airway closure is present. In obese supine position, FRC decreases to the uh, closing capacity, but small airway starts closing and risk of atelectasis and the hypoxemia increases. In the obese Trendelenburg position, the FRC is at the lowest level due to the abdominal content pushing the diaphragm and causing the risk of airway collapse, leading to the increased oxidation. The respiratory comorbidities are difficult airway, obstructed hypoventilation syndrome, obstructive sleep apnea, and pulmonary hypertension. Now, the difficult airway, as the increase in the amount of adipose tissue in the oral and pharyngeal tissues are seen in the obesity, the deposition of fat in the lateral wall decreases the size of the airway and changes the shape of the oropharynx into an ellipse with a short transverse and long AP axis diameter. As the amount of adipose tissue are also seen in the suprasternal region, presternal region, post-cervical, submental, and over the thick neck region. The neck circumference more than the 40 centimeter is the ideal predictor for difficult airway, which limits the limitation of the movement of atlanto-occipital joint. Obstructive sleep apnea is defined as a complete cessation of airflow for more than 10 seconds occurring 5 or more times per hour of sleep, despite of continuous respiratory effort against a closed glottis accompanied by decrease of at least 4% in saturation. Obstructive sleep apnea is hypopnea is defined as a partial reduction of airflow of greater than 50% lasting at least 10 seconds occurring 15 or more times per hour of sleep and accompanied by decrease of at least 4% in saturation. Apnea and hypopnea index is defined as the total number of apnea or hypopnea in events per hour. It is determined by the polysomnography. It indicates the severity of disease. As the event 5 to 15 events per hour occurs, then it's come in the category of mild disease. If the 16 to 30 events occur per hour, then it's come in the category of moderate disease. If the more than 30 events occurs per hour, then it come in the category of severe disease. OSA is characterized by the episodes of apnea or hypopnea, snoring, daytime somnolence, fragmented sleep, fatigue, morning headache, and leads to the decreased cognition and intellectual function. The physiological abnormalities are seen hypoxemia, hypercarbia, generalized vasoconstriction, and this hypoxemia during apnea causes the bradycardia, leads to secondary heart block, which increase the chances of the nocturnal angina and MI. Obesity hypoventilation syndrome is also known as the Pickwickian syndrome. This syndrome is having a triad of obesity, chronic hypoventilation, and pulmonary hypertension. It is diagnosed by when the BMI is more than 30 kg per meter square and PaCO2 is more than 45 mm of Hg. The clinically increase in CO2 during the carefulness is due to the respiratory center desensitization to increase the CO2 and it is managed by the overnight NIV. The effect on the cardiovascular physiology is also we will discuss with the help of pictorial chart presentation. Obesity causes the increased circulation blood volume, which leads to increase in stroke volume and cardiac output that eventually causes the left ventricular enlargement. This shows the left ventricular wall stress increases and leads to eccentric left ventricular hypertrophy. This hypertrophy leads to systolic and diastolic dysfunction and eventually causes the left ventricular failure. And simultaneously, OSA causes the hypoxia and hypercarbia, which causes the pulmonary arterial hypertension and leads to left ventricular enlargement and hypertrophy and causes the right ventricular failure. Simultaneously, hypertension, IHD, and pulmonary venous hypertension also causes the left ventricular failure. In the obesity, eventually right and left, both the heart failures are seen. The total volume is increased in the obese patient is 70 ml per kg, and most of the extra volume distributed to the adipose tissue. Normally, the resting blood flow to the fat is 2 to 3 ml per 100 gram per meter. But if 1 kg increase in the fat above ideal body weight needs 20 to 30 ml increase in cardiac output. The cardiovascular comorbidities are hypertension, obesity cardiomyopathy, ischemic heart disease, arrhythmia, and cold pulmonale. Hypertension. Hypertension occurs due to the multiple factors as hyperinsulinemia causes the angiotensin release, which activate the RAS mechanism and cause the hypervolemia and leads to hypertension. Simultaneously, hyperinsulinemia activate the sympathetic nervous system, which leads to hypervolemia and causes the hypertension. In the lean normotensive patient, this chart shows the balance between the preload and the afterload, that is the normal heart rate, and no stress is seen in the lean normotensive patient. But in the obese normotensive patient, increase in the preload, that is increase in the blood volume, and normal afterload shows that the heart is dilating and dilating to accommodate the volume, which causes the eccentric hypertrophy. But in the lean hypertensive patients, increase in the afterload seen due to the increase in the SVR and normal preload is there, which leads to heart compensate due to the hypertrophy to overcome the pressure, which causes a concentric hypertrophy. But in the obese hypertensive patient, increase in the preload and afterload causes the both dilatation and hypertrophy, which eventually leads to the congestive heart failure. Cardiac arrhythmia. Cardiac arrhythmia occurs due to the fatty infiltration of the conducting system, hypoxia, hypercarbia, electrolyte imbalance, and increase in the circulating catecholamines and myocardial hypertrophy. DVT and pulmonary embolism occurs due to the increased level of fibrinogen, decreased fibrinolysis, hypercoagulable state, and increase in the interabdominal pressure leads to the venous stasis and immobilization. As little as 5% reduction in the body weight leads to the significant reduction in the renin-angiotensin activity in both plasma and adipose tissue, contribute to the reduction in the blood volume. ECG shows the low QRS voltage, left ventricular hypertrophy, left atrial enlargement, and T-wave flattening. And echocardiography shows increase in the cardiac output, increase in the left ventricular end diastolic pressure, and the left ventricular hypertrophy. Now, the effects on patient positioning on physiology. This understands how different position affects the patient's physiology, especially FRC, pulmonary compliance, and circulatory dynamics. In the supine position, the venous return increases, aortic compression seen, and FRC decreases. But in the Trendelenburg position, intracranial and intraocular pressure raised, FRC decreases and venous return increases. But in the reverse Trendelenburg position, FRC level increases and risk of expiration is also there. In prone position, FRC increases, oxygenation improves due to the better VQ mismatch, increase in the intra-abdominal pressure if the abdomen is not increased. Lateral decubitus position, better diaphragmatic exclusion is seen in the non-dependent lung. In sitting position, perfusion mismatch is decreases. Effects on the gastrointestinal and hepatobiliary system. As the obese patients are more prone for the hiatus hernia, giardia, delayed gastric emptying, increased intra-abdominal pressure, and high volume, low pH gastric content puts the obese patient at risk for increased incidence of severe pneumonitis once the aspiration occurs. The most common abnormalities is seen in the increased alkaline aminotransferase level. The obesity is a major risk factor for non-alcoholic fatty liver disease and the non-alcoholic steatohepatitis and cholelithiasis, which leads to the cirrhosis or hepatocellular carcinoma. The effect on the renal, endocrine, and metabolic system, as the type 2 diabetes occurs in the obesities most commonly due to the resistance of peripheral fat tissues to insulin, hyperglycemia, insulin resistance, diabetes predispose the obese patient to wound infection and increase the risk of MI. Di- Dyslipidemia, hyperinsulinemia, hypothyroidism, and metabolic syndrome, and the glomerular hyperventilation is also seen in the obese patient, as the activation of the sympathetic nervous system and the RAS system and the physical compression of the kidney leads to increased renal tubular sodium resorption, which causes the increase in blood pressure, leads to the end diastolic renal disease. The relative risk of developing diabetes increased by the 25% for every 1 kg per meter square increase in BMI above 22 kg per meter square BMI. Now the effect on the musculoskeletal and other system, that is as the increased body weight causes the load on the weight bearing joint, poor posture, inflammation, and degradation, reduces the muscle strength and increases the bone density, which will leads to the osteoarthritis, rheumatoid arthritis, compressive fractures, carpal tunnel syndrome, urinary incontinence, wound infection, varicose vein, lymphadenoma, breast, prostate, colorectal, and cervical cancer. Now the effect on the nervous system, as the obesity not only affect the metabolism and cardiovascular health, but also significantly impact on the nervous system, which contribute to neuroinflammation, increases the neurological disease. Mostly the most common neuropathy occur is autonomic neuropathy and peripheral neuropathy in diabetic patient. Effect on the psychosocial system is depression, low esteem, and social stigma. Metabolic syndrome, also known as the syndrome X, as the cluster of metabolic abnormalities, syndrome X or insulin resistance syndrome. The criteria of metabolic syndrome is abdominal obesity, triglyceride, hyperdensity lipoprotein cholesterol, blood pressure, and fasting glucose. If any of 3 out of 5 is present, then we will call it as metabolic syndrome. Thank you.
That was an excellent presentation, Dr. Trapti. You have covered almost all the aspects of pathophysiology of obesity. And thank you, Dr. Trapti, for laying down such a clear and structured physiological foundation. Now it's clear that obesity impacts almost all the systems, and these changes are directly relevant to how we assess and manage our patient. So on this background, now let us build on this understanding and look at how we can prepare such patients before surgery. And for this, we have our next speaker, Dr. Shahbaz Alam, Professor Anaesthesia in Theerthanker Mahaveer Medical College, who will focus on preoperative assessment and preparation of obese patients. This part is absolutely crucial, actually, from airway evaluation, optimization of comorbidities like diabetes, hypertension, OSA, to planning for anesthesia and post-operative management. So, Dr. Shahbaz, please proceed. Dr. Shahbaz, you are not audible.
Okay. Am I audible?
Yeah, please. Please go ahead.
Yes, sir. Thank you, sir. And good evening, everyone. Before starting, I will express my gratitude to Meenakshi Sundaram, sir, and entire organizing committee for inviting me as a speaker. And today I am going to present a topic of pre-operative assessment and preparation in obese patient. So a very warm welcome to today's webinar on pre-operative assessment and preparation in obese patients. I am truly glad you could join us today. And as we know, obesity presents unique challenges in surgical care, and effective pre-operative assessment is crucial for ensuring patient safety and optimal outcomes. So what we are going to learn today? What are the anesthetic challenges in patients with morbidly obese patients. We will look at the physiological changes and potential complications and how to make it safer. This involves the risk stratification and optimization strategy. Which patients are at risk? We will discuss the risk factors and assessment tools. And how do we select the patients? This includes patient selection for surgery. And which is the best form of anesthesia? We will consider different anesthetic technique and what is the journey of an obese patient after surgery, focusing on the post-operative care and recovery. These objectives will provide a framework for our discussion. So, what are the worrisome in these patients? These patients are having diminished oxygen reserves and they are very prone to hypoxemia. And also they are very sensitive to the sedatives. And there may be high chances to failure to extubate and failure to ambulate the patients if not properly assessed and optimized the patient. As already discussed by the Dr.Trapti, obstructive sleep apnea and the Pickwickian syndrome, that is hypoventilation syndrome. When we think about obese patients, it's not just the weight, it's the hidden risks like obstructive sleep apnea and Pickwickian syndrome that can seriously affect their breathing, heart function, and overall safety during surgery. Identifying these issues early is critical for safe anesthesia planning. So, Pickwickian syndrome is a long-standing case of obstructive sleep apnea. In case of patients, risk factors are BMI more than 50 kg per meter square. There may be alveolar hypoventilation, which may lead to hypoxemia and hypercarbia. And there may be history of heavy nighttime snoring, periodic respiration, hypersomnolence. There may be secondary polycythemia, right and left ventricular hypertrophy, which ultimately lead to right-sided heart failure with or without pulmonary hypertension. Then we will have to assess the risk in obese patients by grading the obstructive sleep apnea, risk of airway problem, assessment of cardiac risk in the form of major cardiac events after the surgery, and assessment of exercise and functional capacity by different methods. So, most commonly used screening test for obstructive sleep apnea is the stop bank criteria, which includes S stands for snoring, T for tiredness, O for observed apnea during nighttime, and P for blood pressure, and B for BMI, and A for age, N neck circumference, and G for gender. 1 point is given for each positive response, and if it is more than 5 or more, then there will be high risk for obstructive sleep apnea. And if a stop bank score is more than equal to 3 plus serum bicarbonate level is more than 28 millimole per liter, then there is also increased risk. Now let us move to the upper airway assessment. So most commonly used modified Mallampatti test. If it is less than more than 2, it predicts the difficult laryngoscopy. We will also have to look for the dentition, hypertrophic tonsil and adenoids, atlanto-occipital joint extension, interinsular gap if it is less than 3, mento-hyoid distance, thyromental height more than 47 millimeter. It predicts difficult laryngoscopy, and ratio of neck circumference to thyromental height. Yep, it predicts difficult laryngoscopy. Predictor of difficult mask ventilations are Bones criteria. If present any of the 2 or more present, that is the patient is bearded, obesity with BMI more than 26, teeth is absent, elderly with more than 55 years age, and having history of snoring, then there is difficult mask ventilation. We can also assess airway by the ultrasonography. We can check the soft tissue thickness at different level, and we can check the volume of the tongue, hyomental distance, and volume of floor of mouth. Then we have most commonly used American Society of Anesthesiologists physical status classification, in which patients with BMI more than 40, that is morbidly obese patient, comes under the ASA grade 3. And if BMI is between the 30 to 40, then it falls under the ASA physical status classification 2. So we can also predict the risk of mortality after major surgery by higher the ASA class, and if patient is elderly, let's suppose that if patient belongs to the ASA class 3 and age is more than 70, then there is 30.6% chances of risk of mortality after the major surgery. Then comes to the cardiac risk assessment by the revised cardiac risk index. It predicts the major cardiac events after the non-cardiac surgery. Major cardiac events can occur in the form of cardiac death or fatal MI, as risk factors are high-risk surgery, ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, diabetes mellitus, or creatinine more than 2 mg per deciliter. As revised cardiac risk index scoring increases, the risk of major cardiac events also increases. Then we have the ACS NSQIP risk calculator, that is the National Surgical Quality Improvement Program developed by the American College of Surgeons. It is an online resource in which we have to fill the different age group, sex, functional status, in emergency case, ASA class, if patient have history of diabetes, hypertension, or previous cardiac events, and dyspnea. Then accordingly, they define the adverse outcome in the form of patient with the ventilator dependency for more than 8 hours, reintubation, renal insufficiency, rhabdomyolysis, and myocardial infarction. Then we have another web-based tool, Gupta's risk calculator, in which we have to enter the age, creatinine, ASA class, preoperative function, and procedure. It estimates risk of perioperative myocardial infarction or cardiac arrest. Preoperative functional capacity assessment can be done subjectively by metabolic equivalent of task and objectively by cardiopulmonary exercise testing, Duke activity status index, and incremental shuttle walk test. METS gives the correlation with adverse perioperative events. One MET is defined as basal oxygen consumption of a 40-year-old and 70 kg man in the sitting position. It is equivalent to 3.5 ml per kg per minute. One MET is a very low level of exertion activities like reading or watching TV, and greater than 10 METs represents highly strenuous activities. So if METs value is less than 4, then poor functional status, and if it is more than 10, then functional status is excellent. Then comes to the Shahbaz breath holding test. We ask the patient to take a full breath, but not too deep, and hold it as long as possible. If breath holding time is more than 25 seconds, then cardiopulmonary reserve is normal. And if it is less than 15 seconds, then cardiopulmonary reserve is very poor. While METs and breath holding tests gives us valuable initial information, further cardiac testing may be necessary. In some patients, especially those with poor functional status, when we need a more detailed evaluation, we need to ancillary cardiac testing. These includes 12-lead ECG, left ventricular functional assessment, exercise stress testing, pharmacological testing, and coronary angiography. A baseline ECG is a standard part of pre-op evaluation. However, it's important to recognize that obesity can influence ECG reading, potentially leading to false positive for certain conditions like inferior wall MI. We might also see micro voltage or non-specific STT changes. Now come to the cardiac stress testing. It is advised when METS score is less than 4. It includes exercise stress testing and cardiac stress imaging. So in case of cardiac stress imaging, reversible defects on cardiac stress imaging are indicative of increased preoperative cardiac risk. The more reversible defect, higher will be the risk. And in case of isolated fixed defects on cardiac stress imaging, they are not predictive of increased perioperative risk. Transesophageal echocardiography is another tool we can use in selected cases. It's often used when we need detailed information about cardiac function or valve issues. We can also check by the dipyridamole thallium or technetium 99 perfusion scan, where exercise testing might be difficult or inconclusive. This scan helps evaluate the presence of ischemic heart disease by assessing blood flow to the heart muscle. Now let's move on to the another important tool, that is the cardiopulmonary exercise testing, which is the gold standard. It is a specialized test for preoperative risk assessment. The subject is exposed to incremental physical exercise up to maximally tolerated level by using an exercise bicycle or treadmill. The work rate is gradually increased in a stepped manner until the subject is unable to continue for maximum of 10 minutes. Mainly two key indicators are derived from CPET, that is the VO2 max, body's maximum oxygen uptake, and another is the VAT, that is ventilatory anaerobic threshold. It is a point at which anaerobic metabolism exceeds the aerobic metabolism. So CPET helps us identify patients who are at significantly elevated risk and may benefit from further optimization or alternative treatment strategies. We can use the Duke Activity Status Index to estimate a patient's functional capacity. TASI is a questionnaire that asks patients about their ability to perform various activities. It helps us to get a rough estimate of the patient's peak oxygen uptake, which we can calculate by this formula. It shows good correlation with the maximum oxygen consumption on CPET. Then we have the simple, valid, and reliable incremental shuttle walk test, in which patients walks along a 9-meter course at a progressively faster pace, guided by pre-recorded signals. The test ends when the patient is too breathless to maintain the required pace or fail to complete the shuttle within the allotted time. We record blood pressure, respiratory rate, pulse rate, dyspnea scale rating, and perceived exertion at baseline and after test. In addition to the functional assessment, we can also use the biomarkers that helps us identify patients at high risk of complications. These are natriuretic peptides, troponins, and C-reactive proteins. As we know, obese patients are at more risk for post-operative kidney injury. High risk factors include old age, obesity, blood urea nitrogen and serum creatinine ratio more than 20, that indicates the dehydration, low preoperative hemoglobin level, decrease in the perioperative hemoglobin level, and low preoperative serum albumin, preoperative treatment with ACE or ARB, and large intraoperative colloid infusion. When assessing risk in patients undergoing bariatric surgery, we have a specific tool called the obesity surgery mortality risk scoring. It is the first validated risk scoring system specifically for the bariatric surgery, but we can also use this for the non-bariatric surgery. A score 4 to 5 indicates the high risk and there is more chances of post-op mortality. Patient factors also lead to high risk, that are the age, gender, and physiological reserve, and also associated comorbidity like cirrhosis, ischemic heart disease, cancer, and preoperative hypoalbuminemia. These are the patient-associated risk factors. And it's also important to consider the risk associated with the type of surgery itself. We must integrate the patient's individual risk factors with the risk of planned surgery to get a complete picture. Post-op pulmonary complications are major concern in obese patients. Risk factors include age more than 60 years, history of smoking or COPD, congestive heart failure, higher ASA classification, prolonged duration of surgery, high-risk surgical type, and planned for general anesthesia. These are the most prone for post-op pulmonary complications. So preoperative pulmonary function test can be very helpful in predicting risk of post-op pulmonary complications. These tests includes spirometry, microspirometers, and ABG analysis. We can also predict the post-op pulmonary complications by calculating the FEV1. If it is less than 1 liter, then we have to advise ABG analysis. If FEV1 is less than 1 liter and there is normal PaCO2 and PaO2, then post-op course will be normal. And if FEV1 is less than 1 liter and there is a high PaCO2 and low PaO2, then patient may require post-operative ventilator. So if the vital capacity also decrease from 70 ml per kg to less than 15 ml per kg, and if there is PaCO2 level more than 50, then there is exaggerated post-operative pulmonary complications. And if FEV1 is less than 1 liter and FEV1 by FVC ratio less than 40%, then post-operative ventilation may be required. As obese patient presents unique challenges in the perioperative period, let's discuss some of these. Venous access can be difficult, so often require the ultrasound guidance. And airway management and ventilation can be challenging due to anatomical and physiological factors. There may be hypoxemia and desaturation. These are more common due to decreased respiratory reserves, and there's an increased risk of aspiration. Positioning can be complex due to body habitus. Monitoring can be more difficult. The choice of anesthesia technique needs careful consideration, and fluid management requires precision, and pain control can be more challenging. So we have to optimize the patients. Optimization involves multimodal approach. It may be medical, cardiopulmonary, rehabilitation, and psychological. Aim of optimization is to improve the functional capacity, enhance recovery, routine standard anesthesia assessment, assess the oxygen reserve, cardiopulmonary reserve. We have to gauge the difficulty of airway, look for all possible comorbidities, concurrent medications, and optimization of the comorbidities. Pre-op rehabilitation play a significant role in improving the outcome. This may include cessation of smoking and alcohol, weight loss before surgery, pre-operative spirometry, and pre-op nebulization. If achievable, benefit of weight loss are decrease in the stroke volume, blood volume, cardiac output, pulmonary capillary wedge pressure. There will be decrease in the left ventricular mass, improvement of the left ventricular diastolic and systolic dysfunction. And there will also decrease in the resting oxygen consumption, systemic arterial pressure, and resting heart rate. It's essential to give the patients clear pre-operative instruction to optimize their conditions. Hormonal supplements like oral contraceptives can worsen the prothrombotic state, so consider discontinuing them. We have to continue incentive spirometry. If patient is using NIV, then it should be continued the perioperatively. If patients are dependent on walkers, then we ask to bring him. And we have to familiarize the patients with the post-anesthesia care unit to allay the anxiety. No sedatives should be given outside the OT. We should have to follow the acid aspiration prophylaxis, antihypertensive medication, thyroid medication, psychiatric medication should be continued, thromboprophylaxis should be given, nebulization given, and omit the oral hypoglycemics. Anticipating the challenges in obese patients means having the necessary equipment readily available. So special equipment needed are for the positioning, heavy weight capacity beds should be required, mechanism for transfer of mechanism should be required, more personnel may be needed, extra long needle for blocks and regional anesthesia should be there, and appropriate size of cuff should be there. We should have the prepared OT as per the patient. Difficulty intubation card should be there with the bougies and stillate and fast track LMA. Or different sizes of oropharyngeal and nasopharyngeal airway should be there inside the OT. As we know, video laryngoscopy is the gold standard, so these should be there. LMA and supraglottic devices of appropriate sizes, optic scope, and front of neck access kept handy. So to summarize, comprehensive pre-anesthesia evaluation for comorbidity is important in obese patients. Additional tests may be needed in patients with high BMI and associated risk factor and need to prepare as per associated comorbidities. And also additional logistic issues due to obesity need to be considered while planning. So I am concluding my session with the obese patients undergoing surgery face unique challenges, including increased risk of post-operative complication and difficulty with standard operating procedures. So comprehensive preoperative assessment, optimization of medical conditions, and special equipment and technique can help minimize these risks. With the right preparation and care, we can ensure safe and successful surgical outcomes for obese patients. Thank you.
Thank you, Dr. Shahbaz. That was a very pragmatic approach to pre-operative planning. Pre-operative preparation is very important for any patient, and especially if it is a obese patient, then it is because a good preparation dramatically changes the outcome of the patient. You very nicely highlighted how to pre-operatively assess the risk factors associated with obesity, like ultrasound-guided airway assessment, RCRI, and various surgical risk calculators, functional capacity assessment, cardiopulmonary exercise testing, and use of biomarkers. So actually, these parameters can identify the patients which might face post-op issues. You also highlighted on how to optimize these patients by pre-op rehabilitation while emphasizing on advantage of weight reduction, which often makes a huge lot of difference on the outcomes of these patients. So now we move on to perhaps one of the most technically challenged phases, the intraoperative and post-operative care. And to sail through this, we have our third speaker, that is Dr. Payal Jain. She is professor of anesthesiology in Theerthanker Mahaveer Medical College. And she is very enthusiastic, and as sir already said, and she is upcoming anesthesiologist and lots of promise. Dr. Payal will guide us through intraoperative and postoperative management. This includes airway management strategies, anesthetic drug selection, use of IV fluids, use of regional anesthesia, thromboprophylaxis, pain control, and post-operative monitoring. So, Dr. Payal, over to you. Please continue.
Madam, you are muted. Dr. Jain, madam, you please unmute yourself.
Hello. Dr. Payal, please unmute yourself.
Hello.
Yeah, done.
Please go ahead.
A very good evening to everyone, and thank you, Meenakshi sir, for such a warm welcome and an encouraging welcome to us. After establishment of that strong foundation of the pathophysiology and the pre-operative assessment and the preparation of the patient, let's continue our journey with the intraoperative and the post-operative management of these patients. As human beings, we are very mindful of our self-image, and thus we have to take these patients with dignity and safety before we take these patients into OT theaters. Ensure the theater gowns of appropriate size, build rapport with the patient, let the patient maintain their own mobility. Be appropriate equipments, chairs, trolleys, and OT tables have to be there with full anticipated maneuvers and the position that the patient is going to take during the surgical course. The transport devices like hover mattresses, patient transfer devices, etc. should be available. These patients are very prone to pressure necrosis. Thus, the malleable bean bags, the gel pads, and the strappings appropriate to the position the patient is going to take during the surgery should always be available. Now, after we have taken this patient on the OT table, the very next thing is the monitoring part. All the ASA monitors are essential. The NIBP may not be accurate because proper size of cuff may not be present. But if we are using a smaller cuff, we are going to overestimate the blood pressure. Forearm can be used for the cuff placement, but we have to be careful that systolic blood pressure would be overestimated and diastolic blood pressure would be underestimated. Whenever need be, invasive blood pressures can be taken. Other than the ASA monitors, or including the temperature, neuromuscular monitoring, quantitative, and BIS monitoring is recommended because these patients are very prone to awareness during anesthesia. Whenever we are standing on the head end of such a challenging case, we all have to remember the anatomical and the physiological changes of the airway. But before inducing this patient, be sure to check the file for the consent, as if the patient has one of these risk factors, he will surely land up in HTUs or for post-operative ventilator. For example, presence of uncontrolled comorbidities, OS-MRS of 4 to 5, or presence of OSA that is untreated. Now, mastering the airway in the obese patient actually requires religious following of the 5 P's of airway management. Please remember that preparation is the key to the success. We have to know our limits. We have to use those devices we are familiar with and we are expert in. Always anticipate the difficulty. Always have a plan B which is prepared. And an expert colleague, an extra hand is always welcomed in such a situation. Coming over to the airway devices, as laparoscopic surgeries are increasing, endotracheal intubation is the gold standard to be used in morbidly obese patients. Supraglottic airway devices can be used, but they are not foolproof and have to be used cautiously and only second generation to be used, as high positive airway pressures are required in these cases. When we talk about awake fiber optic intubation, it's not required in each and every case. Only a case with limited mouth opening, limited neck extension, limited jaw protrusion can have awake fiber optic. Curved video laryngoscopes are highly efficient tools. They've actually shown to decrease the number of attempts. When we talk about rescue techniques, that is front of excess technique, they're actually difficult to execute in these patients. So we have to be pre-prepared by marking the cricothyroid membranes or the tracheostomy site using ultrasonographically before inducing these patients. A difficult airway cart with the expert colleague is a boon to these cases. If we are going to awake fiber optic intubation, be sure not to use those regional techniques of nerve blocks, but eventually we are going to block those nerves who are making the pharyngeal muscles taut. Use conscious sedation instead, like dexmedetomidine. Spontaneous ventilation has to be maintained. Use minimal doses of sedatives and hypnotics for such cases. LMAs can actually facilitate the intubation. Always use apneic oxygenation and limit your attempts so that you don't give a disastrous airway to the next person. Before pre-oxygenating the patient, we have to ensure a good position like ramp and the head elevated laryngoscopic position, where we are going to keep the elevated through pillows or the blankets or towels beneath the neck and the chest, such that the external trachea and the sternal notch are in the horizontal line, which makes the pharyngeal, oral, and laryngeal axis aligned to each other. This is around 20 to 25 degrees. So this is around 20 to 25 degrees, and this is actually important because it is going to buy us 1 minute of safe apnea period. Always use a tight fitting mask such that the capnography comes very nicely and you have an end tidal O2 of 90%. Use a two-hand Thénard grip technique. Always have an OPA or nasopharyngeal airway by your side. Pre-oxygenation is very important in these patients to prevent perioperative hypoxemia. You can use conventional methods like tidal volume for 3 minutes at an FiO2 of 100%. Ensure the rate of 10 liters per minute so that there is no rebreathing. 8 vital capacity breaths in 1 minute can be given. Use non-invasive positive pressure ventilation, especially to the patients who are already using it pre-operatively, at 8 to 10 centimeter water for 2 to 5 minutes. Use pressure supports or PEEP of 5 centimeter for 2 to 5 minutes. Why are we so worried about pre-oxygenation? Because we want to buy the safe apnea period, as this is decreased to just 2 to 3 minutes in obese patients in comparison to normal patients where it is 8 to 10 minutes. Whenever you are introducing the laryngoscope or the fibroscope in the oral cavity of a morbidly obese patient, kindly ensure apneic oxygenation. This can be given through Thrive or use of a 10 French catheter through nasopharynx, or a buccal RAE tube can be put into the buccal cavity and attached to the oxygen. Talking about RSI, is it actually necessary in each and every case? The answer is again no, because if we see obesity as a single morbidity, it does not increase the risk of pulmonary aspiration. Routine fasting guidelines have to be followed, and a non-premedicated, non-diabetic, fasting obese patient with no significant gastroesophageal pathology should be given a 6 hours of fasting and 2 hours of clear liquid. If in doubt, use POCUS to check the gastric volume. The problem with RSI is that we already have a very difficult laryngoscopic view and intubation in these patients, and cricoid pressure is going to make it more detrimental for us. Now comes one of the most controversial parts of obesity, that is the pharmacology part. Now, to know about what dose and which weight scaler has to be used, we have to understand that loading doses have to be given according to volume of the distribution. A drug that goes to the lean tissue and adipose tissue equally has to be given according to the total body weight, and a drug that goes only to the lean tissue should be given through lean body weight. The maintenance doses of the drugs are given using the clearance. If you have a similar clearance in obesity and non-obesity patient, go for lean body weights. But if the clearance is more in obese patient, you can go for total body weight. Now, these are some rules that we have to think before giving the dosing. The first, we have an increased blood volume as already discussed, which leads to decrease in the plasma concentration of rapidly intravenous drugs that we administer. Plus, we have reduced free fraction of the drugs because of hyperlipidemia and increased alpha-1 acid glycoprotein, which will make us give a higher dose. But we have to remember that accumulation of lipophilic drug is there in the adipose tissue. They get sequestered there, and then slowly and steadily they are released from this fat depot, which makes the elimination half-life very prolonged. And that is irrespective of the clearance of the drug. In obesity, the renal clearance of the drugs does increase, but still they have a prolonged elimination half-life. Please remember that fat has a poor blood flow. Thus, the doses, if we calculate only using total body weight, is actually going to lead a very excessive plasma concentration. Phase 1 metabolism remains unaffected, but the phase 2 metabolism is enhanced. So actually, we calculate the loading doses either using lean body weight, ideal, or adjusted, depending upon the drugs. And then we see the effect of that initial dose and titrate to the effect. The best part is that if you are giving an oral drug to obese patient, the bioavailability will always remain unchanged. Now coming over to the individual drugs, the pre-medications. Opioids are always given using lean body weight. Talking about benzodiazepines, they are given again using lean body weight because the obese patients are very sensitive to the effects of opioids and benzodiazepines. For pre-medication, we have to ensure the giving of antimicrobials, H2 receptor antagonists, proton pump inhibitors, and preemptive analgesia is encouraged in obesity in the form of pregabalin, gabapentin, and melatonin. For the prophylaxis of prevention of PONV, give dexamethasone or haloperidol or ondansetron. Thromboembolic stockings are encouraged in obese patients. The induction agents have to be given as titration to the effect. Adjusted body weight are used to give the induction agents, whether loading or as an infusion. Talking about this scopolamine, that is the most preferred skeletal muscle relaxant for induction, the levels of pseudochlorine esterases increase, so use your total body weight. Talking about the maintenance by non-depolarizing muscle relaxants, all the drugs are given using ideal body weight or lean body weight, but never total body weight. And if the patient has organ failure, atracurium or cis-atracurium are the NDMRs of choice. Maintenance with TIVA or inhalational, TIVA is always preferred because of rapid offset of action, rapid clearance of the hypnotic agents, and clear-headed emergence. If we are talking about the inhalational agents, then Sevoflurane and desflurane are more preferred because of their less fat blood gas partition coefficient, thus rapid offset. In the maintenance, nitrous oxide can be used because it has a rapid elimination, but FiO2 requirements of obese patient is higher, so it's optional to be used. Always use short-acting opioids as maintenance, and dexmedetomidine is a very attractive adjuvant in it. These patients are very, very prone for awareness because of the rapid redistribution of the IV anesthetics, thus ensure adequate dosing of the drugs. Use BIS or continuous vital monitoring of these patients. This is another chart in which various drugs are given and the dosing scaler that has to be used. Out of this, I want to emphasize on one drug specifically, that is the atropine. Never give lesser doses of atropine because one can land in reflex bradycardias in obese patients. Talking about the reversal agents, adjusted body weights are used in reversal agents, and for neostigmine, never to exceed the dose more than 5 milligrams. Now coming over to the fluids, of course, the excess of adipose tissue makes it very difficult to actually assess the peripheral perfusion. Blood loss has to be expected to be more in obese patients in comparison to non-obese patients. Our aim is to maintain normal bulimia using balanced salt solutions. You may use goal-directed fluid therapy or zero fluid therapy depending upon the case, but the body weight that we have to use is adjusted body weight to calculate the fluid requirements. Rapid infusions of intravenous fluid have to be avoided because they are very prone to biventricular failures, and these patients also have a protracted volume. Obese patients are at very high risk of acute tubular necrosis. Coming over to the ventilatory settings, lung obviously does not increase in size with the obesity. The ventilatory mode is pressure controlled ventilation, volume guarantee. Tidal volume 6 to 8 ml per kg. The weight that we have to use is idle body weight. Respiratory rate has to be maintained, such as to maintain normocapnia. We don't want hypocapnia as well as hypercapnia. Even if we decide, then permissive hypercapnia is still fine. FiO2 has to be ensured such that SpO2 is just 90 to 92% and FiO2 of 0.4 to 0.5 because we don't intend to have resorption atelectasis in these patients. Airway pressures have to be maintained to less than 30 centimeter of water. These patients require recruitment maneuvers. Give inspiratory pressures of 55 centimeter water to open the collapsed lung and then continue, and this has to be given for 10 seconds only, and then continue with the PEEP of 10 centimeter water depending upon the cardiac status of the patient. And this is known as the open lung concept of the obesity. In long duration surgeries, these maneuvers have to be actually repeated every 45 to 60 minutes. Now comes another challenging part, that is the extubation, which actually has to be planned very meticulously in these patients. Ensure that the patient is in semi-recumbent position. Use nasopharyngeal airways. Have airway exchange catheters. You can do Bailey's maneuver. Always extubate when the patient is awake and obeying commands. Emergency airway cart has to be ready. Extra hands are always welcomed. Sugama Dex is preferred. Be patient. Let the inhalation anesthesia first get washed out. We are not going to extubate the patient who is hypocapnic and even hypercapnic. Ensure FiO2 of 100% and end-tidal oxygen of 90%. Avoid premature extubation of these patients. The criteria for extubations are the head lift has to be there for more than 5 seconds, hemodynamically stable, normothermic patient, adequately reversed with a respiratory rate of more than 10 but less than 30, SpO2 of more than 95% and an FiO2 of 40%. Vital capacity, tidal volume, inspiratory driving pressure have to be maintained. Talking about the post-operative concerns, we should have a stringent monitoring for at least 1 hour in these patients, as these patients are very prone to obstructive sleep apneas. But this risk remains there for at least 1 week post-operatively. And that is why we have to be ensured that whenever we are discharging these patients, we have to use screening tools and a reliable assistance. The problem with these patients is that on the POD 1 and 2, they have fragmented sleep and their suppression of REM sleep is there, because of which at POD 3 and 5, they actually have a relapse of increase in the intensity and duration of their REM sleep, which makes them very prone to nocturnal respiratory disturbances. So ensure these patients have supplemental oxygen till 24 to 72 hours post-operatively. But this is not that we have to hyperoxygenate this patient. We have to look at the SpO2 levels as well as the EtCO2 levels at the same time. Ensure the presence of naloxone if we are intending to give parenteral opioids to this patient post-operatively. The position of the patient will be elevated head 30 to 45 degree. Padding of the pressure points is important. Prevent AKIs and post-cognitive dysfunction in these patients. As I've already told, these patients, around 75% of morbidly obese patients will have obstructive sleep apnea. So watch out for respiratory rates less than 5 breaths per minute for 20 seconds, oxygen saturation less than 85 seconds, apnea appearance lasting for 20 seconds, EtCO2 less than 15 or more than 60 mmHg. We have to ensure a respiratory support to these patients in the form of CPAP. It is said that if we start using CPAP just after extubation on the OT table, it is much better than starting the CPAP in the PACU. You can give BiPAP to the patient at 12 to 4 centimeter water, pressure support ventilation, PEEP, deep breathing exercises, incentive spirometry are highly encouraged. Post-operative period has to be analgesia, that is pain-free. But because of the fear of the side effects, sometimes we undertreat this problem. So use multimodal analgesia, which is opioid sparing. Early mobilize the patient. Use peripheral nerve blocks. Preemptive analgesia. You can use drugs such as ketorolac, clonidine, lignocaine, dexmedetomidine, gabapentin, etc. Local wound infiltration is encouraged in these patients. We can use intravenous patient-controlled analgesia, but we don't give a continuous infusion in these patients. Post-operative nausea and vomiting can be detrimental for these patients. So in order to avoid it, give a positive fluid balance of 1 liter at the end of the surgery. Good post-op analgesia should be there. You can use drugs such as dexamethasone, opioid-free, nitrous-free anesthesia, dexmedetomidine, ondansetron, and in refractory cases, one can have epipitant. Post-op venous thromboembolism is yet another thing that we have to be careful of. Generally, the dose of the low molecular weight heparin is not dependent upon the weight. We can have start doses depending upon whether we need prophylactically like 40 mg OD or we need therapeutic doses depending upon the risk factors of the obesity, that is 60 mg 12 hourly. These criteria, Monter obesity surgery score, can help us to know which patients have to be shifted to HDU. The discharge of the patient is dependent upon the vital signs, 20% of the baseline, adequately treated nausea and pain. The patient has to be free from apnea and hypoventilation without stimulation. That is when they are sleeping, and they should pass the room air challenge test. The patient should be able to use CPAP and should have a reliable assistance. Talking a little about the regional anesthesia, we all know the advantages of regional anesthesia over general anesthesia, but still we have a lot of concerns when we talk about morbid obesity patients. For example, difficult positioning. Sitting position is preferred, but one can go for the lateral position also, but please ensure that your patient is just at the edge of the bed such that the lateral deviation of your needle is minimal. They have a limited back flexion. The most difficult part is identification of the landmarks. One can use an ultrasonography, that is to have a assumption of the depth from the skin to the epidural space, but it could be erroneous because the transducer actually presses the subcutaneous tissue. You can draw a line from the cervical spinous processes till the upper part of the gluteal cleft, another line of the skin folds touching the iliac crest. And where these two vertical and horizontal lines meet, we can insert our needle. One of the best parts is we can ask the patient himself or herself also, are you feeling a finger on your back? And he can help us out with it. We can have a false loss of resistance in the epidural because of the subcutaneous tissue. We need some special equipments. Now, because of the decreased cerebral spinal fluid, we can have a cephalic spread of the local anesthetic, for which we have to decrease the volume of LA by 20%. These patients already have a large buttocks and thus in Trendelenburg position. So whenever you are changing the position from the sitting to the supine, please keep a chest ramp such that your cervix and cervical and the thoracic area are higher than your abdomen. Now, the major problem with the epidural is the catheter dislodgement. So the fixation of the catheter has to be done very properly in these patients. Suppose you're putting the epidural in a sitting patient, but don't fix it in the sitting position. First, let the patient be in the lateral position, check the movement of the catheter, ensure the patency of the catheter, and then fix it. Talking about peripheral nerve blocks, again, it is a bit challenging. So you can use ultrasound plus PNS guidance for the same. Coming to the last slide of my session, that is the daycare surgery. Which patients are appropriate for daycare surgery? Every patient of any BMI can go through daycare surgery. It only should have a good functional capacity. The OSA or OHS should be effectively treated using CPAP. The patient should be able to continue the venous thromboprophylaxis even at home. That is why the oral anticoagulants are coming in being and should have a responsible assistance. Talking about the anesthetic and surgical factor, it is the adequate time of surgery and anesthesia, as these patients also require a stringent monitoring of 7 hours. Thank you. Now I hand over the mic to Mukesh sir for concluding the session.
Thank you, Dr. Payal. It is once again, a very excellent presentation. Thank you, Dr. Payal, for such an insightful presentation. Managing obese patients in OR really is a test of both preparation as well as adaptability. The importance of vigilance in intraoperative and post-operative period, especially with patients at risk of OSA, cannot be overstated. You very aptly highlighted the 5 P's of airway management, importance of difficult airway cart, pre-oxygenation, importance of patient positioning and avoiding RSI, use of ultrasound, and the calculation of drug dosing, perhaps one of the most confusing part, is very well dealt with. Dr. Payal has focused on how to administer IV fluid, whether it is goal-directed or zero-balance approach. She also highlighted the use of multimodal analgesia, avoiding opioids, and successfully using regional anesthesia along with non-opioids, which makes a huge lot of difference in these patients' outcome. So few questions are there in chat box for you, Dr. Payal. Sir, may I proceed?
Yes, sure.
Yeah. So this question is from Meenakshi sir. He is asking why topical or regional anesthesia should not be used in FOV for obese patients. What is the cause?
Sir, once again, sir, a correction, please. Questions are not from Meenakshi, sir. It is through Meenakshi, sir. People call me over phone instead of typing. They wanted to know. So, right, I said then I will post the questions.
Okay, sir. So Dr. Payal, this question is for you.
It is because if we are going to block the nerves, that is going to actually make the pharynx more collapsible, because those are the nerves which are making that muscle taut, and we don't want the pharyngeal collapse to be there. That is why we don't prefer for regional blocks in a morbidly obese patient if we are planning a wake fiber optic.
Yes,
and we go for conscious sedation instead.
But see, that slide mentioned the topical bar regional anesthesia is not indicated. So topical, it will not produce motor block.
Topical, we can use the 10% sprays, and yeah, topically we can
So because
nerve blocks should be, nerve blocks are not preferred.
That is right. That's why again, as a corollary, I want to say, as your presentation was good, I want to correct. You said you add one more colleague in the problem. in a problematic situations. Have one help of the one colleague, your colleague, expert colleague, to help you in the anesthesia. You have put up another first slide when you are managing the thing.
Yes, sir. We need extra help.
Yes, that colleague, that there is a spelling mistake, you have put only one L. You have to add one.
Okay, I'll check to that.
Because see,
I'll definitely check to it.
when you want to add one more person, you add one more L, you add one more L so that the colleague will be correct. Thank you.
Done, sir. I'll check the spellings of the colleague.
One more thing I would like to add is, since there is anatomical deformation, so it's difficult to perform these blocks, especially if you are performing a blind block. So use of ultrasound you can perform, but again, she is very correct in saying that the chances of collapsibility is always there. So the second question for you is, how you are going to maintain airway pressure of 50 to 55, and what is the technique that you are going to?
You said
we can do it by using the.
You said the airway pressure is maintained. Normally it is 30, but you want to keep it to 55.
No, sir. Airway pressures are not kept till 55. It is only for a period of 10 seconds. That is, we are using the recruiting maneuver. We have to recruit the basal atelectasis, the alveoli that have collapsed. Just to recruit them, we use the airway pressures, that the inspiratory pressures of 55 centimeter water, and that is only to last for 8 to 10 seconds and not more than that. And after that, we have to give a PEEP of 8 to 10 centimeter water, depending upon the hemodynamics of the patient.
Madam, I stand corrected. You want to say the peak inspiratory pressure is at 55. But you mentioned
only for 10 seconds.
Yeah, that is
we
right.
have to do it.
So
That's it.
that
Only recruitment has to be done.
Recruitment only, sir.
Only recruitment. We don't have to keep it at that level.
So the next question is whether BiPAP should be fixed to 12:4, whether it is appropriate or not.
It depends upon, we have to actually monitor that patient, the EtCO2, the saturation, the ABG analysis, the respiratory pattern. It will all depend upon the monitoring and how the patient behaves. We can set the BiPAP on 12:4. Suppose the patient is already pre-operatively on a CPAP or the BiPAP. So empirically, we can start on that very setting only, and then we can change the setting depending upon the monitoring and the investigations that we do.
Yeah, madam, I want to point out that clarity was not there when you explained. Even while we are projecting the slide, you said BiPAP was 12/4. It is fixed. You have put up a mark. But now what you say is correct. It is a varying. It is not a fixed.
You can vary it upon
because even your previous in that flow chart, the previous above the thing it was shown, keep a PEEP or CPAP of 8. CPAP of 8 you have put up the thing.
That is the starting, the empirical
that
is
is
starting,
then
and then we can change.
When it is 12:4 means, I think a CPAP or BiPAP, that is BiPAP, the 4 is your meaning a PEEP or CPAP. That is 4. That
BiPAP 12 is IPAP, 4 is EPAP.
Oh, yeah, EPAP, that is what. See, well, IPAP will deliver the tidal volume. So it depends upon, it decides the carbon dioxide elimination, and your CPAP 4 decides oxygenation because it is CPAP. It is the EPAP. What you mean is EPAP of 4. So EPAP of 4 for obese patient, I think it is very less. Very less. And again, as you say, that 12:4 is right in the sense that should be always a difference of 8 between IPAP and EPAP. So that 8 is maintained. But when previous thing you say it is 8, suddenly it is reduced to 50%. 4 will not, even for normal people while we are ventilating IPPV with the PEEP, even the anesthesia ventilators, we ventilate with the PEEP of 5. So a CPAP of 4 for a obese patient, I think it is less.
So we just have to start with it and then we can change it accordingly.
So that is the point, madam. Take home messages, it is dynamic. It is not static.
Yeah, it's a dynamic. It's dynamic. Because we have to balance between not hyper-oxygenating those patients, because we can't take the drive of hypoxia and hypercarbia from them.
But your RAM positioning, everything, the slide, presentation, everything is good. It is a complete. Now we are happy about Theerthanker Medical College. It is a complete. Even from your PG, when your PG started, I was worried. She is consuming a lot of time. But with the military precision, you have finished at 7:30. When you say as a last slide, it was 7:29. Now the discussion is going on. See,
True,
when you
sir.
put up, because as an organizer, I am concentrating on that. When you say as a last slide, it is 7:29. I was very happy. So that shows your military precision controlled by the commander, Dr. Mukesh Prasad.
Thank
It
you,
is good.
sir.
It is really good. It is phenomenal. This is how it should go so that people will enjoy. See, even I used to say intelligent people will not listen more than 45 minutes. That is the reason why we say 30 minutes per speaker. But
So you cannot.
Your PG is talking like a professor. She has consumed actually 17 minutes instead of 10. But Shahbaz Alam, he has curtailed it because I am monitoring. I want to give the genuine feedback. We are extremely happy from Pudukkottai branch that you have done it commendably well within the allotted time. Super.
Thank you, sir. Thank you.
Thank you, sir.
So, do you have any more questions, sir? Or
No, sir, you can pass your concluding remarks, sir. Then we will
okay.
go. Thanks.
Okay, sir. So, sir, if you will allow me, this is not related to this seminar, but I would like to share my screen. This I just made
So,
in between.
you can.
Hello.
Hello. Yeah. Sir, this is a book that we have published just 6 months back, and I don't know how, but we have already 5,000 access in 6 months. So I would like to share this achievement from our department. Dr. Payal, Dr. Shahbaz has contributed a lot in this. So this is just this is the thing that I wanted to share with you. And so, sir, now I want to conclude it by saying one thing, that one thing I would like to highlight is that the prevalence of obesity in children, it has increased dramatically these days due to unhealthy food habits and many other physical and psychological factors. This increase has also spiked associated comorbidity conditions that present additional challenges during the anesthesia. Although many do not manifest until adulthood, however, precursors of these disease are seen early in severely obese children. So anesthesia in obese pediatric patient is more challenging than in adult due to immature organ system, faster desaturation. They desaturate very fast, and complex drug dosing. Moreover, children have a smaller and more collapsible airways and are more prone to hypoxia and thermoregulation issues. And regional anesthesia itself is very difficult because they are not cooperative, and these patients need your psychological support along with family involvement also. So I would like to highlight this, and this is one of the important aspects that we need to ponder on. So, sir, to conclude my talk,
Thank you very much, sir.
sir, pardon, sir.
Please, sir, please proceed.
Yes, sir. So, to conclude, the perioperative management of obese patient is complex but manageable with right knowledge, planning, and teamwork. This is the concluding line that I can say after all this. And before ending the session, I would like to extend my sincere thanks to our speakers, Dr. Trapti, Dr. Shahbaz, and none less than Dr. Payal for sharing their expertise, and to all you for participating. Thank you, sir. Thanks once again for giving us this platform.
Thank you, sir. Thank you very much. We are happy actually to manage obesity. All people, the faculty being very slim. The slimmest, the slimmest
True.
Payal Jain madam is controlling obese. So that is so nice. So anyway, madam is interested in cooking and reading also. But I think whatever she cooks, she will not eat. That is the reason why she is very slim.
It is distributed in departments, sir.
And Dr. Shahbaz is a good cricketer and a badminton player. Sir is a good artist. So he's sketch making. Mukesh sir is perfect in that. And even in obese, if he makes a sketch, the consumption of paint will be more. So that is a problem with obese people. So we expect Dr. Trapti also to join the bandwagon of you, and we thank you profusely. Now I request Dr. Hema, our treasurer, to propose the formal vote of thanks.
Thank you, sir. Good evening, everyone. Thank you. I thank you all for your participation in today's episode on the topic obesity. I thank our academic chairman, Dr. A.L.M. sir, for guiding us throughout the series. Thank you, sir. I thank Dr. Trapti Singh, postgraduate, Theerthanker Medical College, Moradabad, on the topic on pathophysiology of obesity. Thank you, Dr. Trapti. I thank Dr. Shahbaz Alam, Professor, Sir, Theerthanker Mahaveer Medical College and Research Center, Moradabad, on a topic on the preoperative assessment and obesity. Thank you, sir. I thank Dr. Payal Jain, on Madam,